So welcome to Urogynecology and Pelvic Healthcare. So today, as we discuss a lot of topic today in this Urogyne with various gynecologists, various urologists and urogynecologists. And today we have with us dedicated urogynecologist with us. Yes, that's none other than Professor Seethalakshmi ma'am, Professor and Head of Department of Urogynecology Department, Savida Medical College, Chennai, India. So welcome ma'am.
Welcome. Good morning.
Good morning ma'am.
Good morning.
Ma'am, how has been journey? First, before discussing the topic today, we just want to know how the journey for was like. You dedicatedly practice urogyne, and so how has been the journey?
Yes, I initially in my postgraduate degree, the thesis was urological injuries and in obstetrics and gynecology.
Okay.
That is how I developed a passion towards urogynecology.
Okay.
And I love the urogynecology subject, and that makes me to read and do more things in pelvic floor, and the journey started like that. Now I have a lot of research project involved in doing the pelvic floor organ prolapse, and the journey is like that.
Okay. And ma'am, how you feel there was like a long journey? So initially in the residency when you did the thesis and at present, so how is the urogyne cases which has been increased, which has decreased, and how it's like it is increasing in number, decreasing on which cases?
Urogynecology cases are increasing because previously the patients are not aware of the field. They live with their tragedy. They don't reveal their urinary incontinence, fecal incontinence, prolapse uterus. Now they are aware through the healthcare workers that the treatment is available for urogynecological diseases. And I stress my residents, OBG residents and other urology residents to ask about the urogynecological history in patients whoever come to their OPD department with complaints of pelvic floor disorders.
So this you think very nice, ma'am. Like you say, urology residents also, because not all, very few urology people also want to do a fellowship or excel in urogyne, because it's something combined. That's why only this branch has emerged as a urogyne. So do you offer some training to that also, and how it's like combined urogyne department over your college?
Urogynec department is different in our
from
college.
Gynae and urology.
Gynae and urology. Because urogynecology is a subspecialty of gynecology which deals with the female pelvic floor disorders. So it is a separate department.
So there
it is urogynecology. Many believe that urogynecology means only prolapse and urinary incontinence. It is not like that. It includes, so all public believe like that. So it includes a lot of pelvic floor disorders, including female sexual dysfunction, chronic pelvic pain, and so many things in the pelvic floor. So Department of Urogynecology can deal with that.
So ma'am, as you said, it's a totally different urogyne department. So their urology residents also come to learn, or it's...
No, that is not yet decided. In future, we may think of it.
Okay, fine. So we'll start with ma'am today's topic, that is evidence-based best route for pelvic organ prolapse repair. So what the evidence is? What is the pelvic organ prolapse repair?
See, there are lot of methods and lot of routes for repair of pelvic organ prolapse. And usually the vaginal route is the study evidence says 90% of pelvic organ prolapse surgeries can be managed by treating vaginally because it is easier and all other compartment defect can be addressed simultaneously at one sitting. Suppose if you do abdomen laparoscope or a robotic, it needs a change of approach. All cannot be done through a laparoscopic approach.
So that is, I think, very important message, that if you do vaginally prolapse repair, you can simultaneously and see also, ma'am. What happens, a majority of cases, you residency में what I have seen, what जब तक वो rectocele तक आता ना तो फिर हो जाता है यार इतना rectocele नहीं है, करने की जरूरत नहीं है. Means we happens. And if you switch over to abdominal, that vault will get pulled up. So जो rectocele जो पहले grade 2 था, if you do it laparoscopically, afterwards we see only one, then we say let it be. But some months, years, patient come again. So it's better.
Usually abdominal sacrocolpopexy may predispose to constipation. So rectocele has to be corrected along with the genital hiatus narrowing when abdominal sacrocolpopexy is done. whether open or laparoscope.
We start with first rectocele only, the posterior compartment. So when it's rectocele, if you want to repair, so how can we approach? So what is the difference between site specific, traditional posterior colpororrhinography, or is everything is same?
First, we have to assess whether it is an isolated level 2B compartment, that is rectocele, or it is associated with apical defect also. Because majority of the rectoceles are associated with apical defect also. Suppose if the apical defect is there, we should aim apical suspension along with posterior compartment defect repair. Otherwise, the posterior compartment defect repair will fail if the apex is not adequately suspended. I insist all the residents to understand that the apical compartment defect should be repaired when it is associated with posterior compartment or anterior compartment. If the apex is not adequately supported or suspended by your repair, whatever you do anterior or posterior repair, it will fail because the apical reconstruction is the cornerstone of the pelvic floor surgery. Suppose if it is an isolated rectocele, we may go for site-specific defect repair. That is, identifying the site defect and repairing that alone. Or you do the traditional posterior colporrhaphy by approximating the rectovaginal fascia in the midline and the vaginal muscularis. That gives the transperineal approach is very greater result compared with the transanal repair for posterior compartment repair.
So as you said, ma'am, the apical should be addressed. I think majority we know that anterior compartment hai to hi apical bhi tha, but posterior also apical is equally good as you said. So suppose we take a case scenario, a 35 years old female comes with anterior wall prolapse, posterior vaginal wall prolapse, and she's having very mild grade 1 cervical descent. Okay, it's just mild, but she is bothered, has symptoms of anterior and posterior compartment. Now, so how we subject it to the surgery? So when we do, so the grade 1 also should be addressed, apical, or we should just do anterior and posterior colpoperinoplasty?
Yes. Suppose if it is a stage 1 cervical descent, that is level 1 defect, cervical descent, under anesthesia,
it comes to level 2.
Yeah, it will come to stage 2. She is only 35 years old. So you assess the infravaginal elongation of the cervix, whether it is present or not.
Okay.
Suppose if the elongation of the cervix is more, you can do a Manchester surgery with the fixing of uterosacral ligament over the cervix and then do the anterior repair and posterior repair along with the narrowing of genital hiatus is more than enough for this 35-year-old patient.
In this, suppose if there is no cervical elongation and it's just true a prolapse.
Yes, it is no apical descent and only anterior and posterior defect is there. Then you do anterior and posterior repair alone. And in anterior repair, you please maintain the trapezoid attachment of the bladder should be restored. That is the very good step when you do the anterior colporrhaphy for isolated cystocele. So should maintain the trapezoid attachment of the bladder. In such cases, the cervix will also go above the ischial spines. So you should see that the pericervical ring is formed after hysterectomy.
So okay, this we'll discuss. This ma'am, as you said, if there is elongation, do the Manchester procedure and do this. But if there is no elongation and she is having pre-anesthetic checkup grade 1 and then under anesthesia, it might be from grade 1 to 2.
Great.
So what to do at that? We should leave it, just do the anterior and posterior, or
if it comes below the introitus under anesthesia, if you think the cervix comes below the introitus, then you can address the Manchester apex by doing the Manchester.
Oh, fine. This is done.
Otherwise, it will fail. If the apex is not supported, then the anterior and posterior repair, whatever good repair you do, it will fail.
Sacrospinous hysteropexy? Because Manchester, if there is elongation, then only will do. But if there is no elongation, then?
For stage 1 to 2, I think Manchester is enough.
Okay, but if there is no cervical elongation, that time also Manchester?
If there is no elongation, only anterior and posterior repair.
Repair is sufficient, okay. That will take care, okay.
Yes.
Now, in posterior colpoperinoplasty, one thing you said site specific, do the fascia and the muscularis. What about levator anapplication?
Yes,
At
in
which age
yes,
and what
35 years old, levator plication is not needed because it causes dyspareunia and constipation.
patient.
So I advise the levator myopathy only in colpoclysis.
Okay.
Only in
Because
colpoclysis.
success rate will increase.
Yes, because the success. And usually levator myopathy is commonly done in colpoclysis.
That is a must because
Yes.
that treatment is incomplete without
Yes,
that.
not with all other cases.
Okay. So this is thing one is done, and which suture material to use for posterior colpoperineal
Colpoperineal 20 delayed absorbable sutures, polyglactin, that is Vicryl.
Vicryl 20. And vaginal mucosa?
Vaginal mucosa also 20.
Same.
Yes, same.
Use of Vicryl rapid?
Rapid Vicryl is not advisable.
Not for the mucosa also. So, okay. So, any case, basically with rectocele, if she's having posterior compartment, better to go for vaginal.
Yes.
This is not there. Okay.
And I advise perioperative pelvic floor muscle training 3 months before undergoing surgery and should be continued lifelong to increase the pelvic floor strength, which the evidence says the patient has a greater relief in urinary symptoms, bowel symptoms, sexual symptoms, with a greater improvement in the quality of life. That is the evidence
and
based.
And even whatever stage it is, because means 1 or 2 we usually first prefer the conservative management only, but if it's later stage 3, stage 4, then also we should
even in stage 3 and stage 4 perioperative and post-operative pelvic floor muscle training
any reason
is
specific
successful.
Stage 4 prolapse, why they should be advised pre-operatively also 3 months, as you said, it should be both pre and post. Perioperative. So whenever suppose stage 4, then also what's the role? Means they will learn and they'll come to know.
Stage 4 also, whatever the ligament and muscle is there. So once the pelvic floor training, it can cause the pelvic floor muscle tone to such an extent that further consequences like vault prolapse, incontinence can be prevented by adequate muscle training, which gives a muscle strength to some extent. That is more important. I believe strongly in that because in my follow-up patients, pelvic floor muscle training, apart from surgery, along with the estrogen
with the help
cream,
of physiotherapist,
we have a separate Jogo clinic in Chennai. So they train only the pelvic floor muscles. They are pelvic floor muscle trainers. So they specifically teach and they see whether the patients are doing correctly
or not.
So that is very important. That is very important. Who teaches the pelvic floor muscle training is very important.
Supervised and proper certified physiotherapist is important to have a very good results. Okay. So, for the cystocele, ma'am, if the patient is having cystocele anterior colporaphy, then how to proceed for that?
For cystocele, only isolated cystocele, you can do the anterior colporaphy, that is midline plication of the pubocervical fascia, that should be followed by restoring the trapezoid attachment of the bladder. That is by fixing the uterosacral ligament, starting from the uterosacral ligament, pubocervical fascia, and then take the sutures in the peritoneum when there is hysterectomy. Suppose if you are doing only isolated, you have to take the substance of isthmus of the cervix without including the endocervical canal, and then the opposite side pubocervical fascia and uterosacral ligament. So 2 to 3 sutures. This restore the trapezoid attachment of the bladder when the uterus is in situ, and this should be followed by the midline plication of pubocervical fascia. Along with, if you see that there is a lateral cystocele, you can fix the vaginal muscularis to the ipsilateral arcus tendinous fascia pelvis with the 2 stitches on either side is give you a better anatomic results in your 1 year follow-up.
Okay.
And I use a trapezoid attachment. I use the non-absorbable synthetic sutures.
Okay, proline. Ma'am, just as you said, trapezoid attachment, if this isolated cystocele repair, uterocycle at what level it should be taken? Like it's behind, so directly going, or we should need to dissect it?
You have to dissect. If the uterus is in situ, you have to dissect the bladder.
From the posteriorly or anteriorly only we can
Anteriorly.
Okay, anteriorly,
Anteriorly, you hold
dissect.
the cervix, put a incision around the circular incision
Circular.
transverse.
Okay.
Mobilize the cervix for a distance of 2 to 3 centimeter, so that you can take the
Uterosacral.
no, you can take the stitch on
Pericervical.
the anterior
Cervical
surface
tissue.
of the cervix.
Cervix. And uterosacral?
Uterosacral cannot be taken when the uterus is in situ.
That's
Suppose
only
if you are doing the cystocele repair after hysterectomy, then you have to take the uterosacral ligament,
that is important
pubocervical fascia, UV fold of peritoneum,
and the
opposite side
same
pubocervical
thing.
fascia and uterosacral ligament.
So, but if you uterus in situ, then you just take the cervical tissue,
Yes.
pericervical, and the peritoneum
and the pubocervical fascia,
of which
cervical isthmus of the cervix,
and that is by
non-absorbable sutures.
So, in
Yes,
pubocervical also proline
yes,
you
it
take it.
can be taken.
Okay, just
Yes.
one stitch, from
1 or 2 stitches.
stitches from
I
this
usually take 2 stitches, 2 to 3.
2 to 3, 2
Yes.
to 1.5 centimeter
Yes,
apart.
yes.
And in the circular fashion.
And then you do the pubocervical
Cervical
fascial
midline
plication
fascia.
in the midline.
And if it's lateral defect paravaginal, then you obliterate the lateral sulcus.
Yes, yes.
And that is by which
With
suture material.
Vicryl, 20 Vicryl.
With Vicryl 20. And any role of site specific in this, or we should do it like site specific repair?
Site specific defect repair you can do, but the current evidence says the proper plication of pubocervical fascia and the vaginal muscularis and the correction of lateral cystocele has the better outcome than the site specific defect repair.
Okay. And
But
when
it
you
can be combined with this.
both, if there is you can see, then you should obviously
you correct it.
customize patient.
Yes.
It's not like definitely do this
Yes,
only
yes.
and that thing. So, ma'am, like when you do the midline plication, you do it intermittent or continuous?
Intermittent. Always intermittent.
Always intermittent.
Yes.
Okay. So I think very few surgeons do continuously
No,
also.
it is intermittent.
So, this ma'am, now suppose you take a case scenario, a 45-year-old female, she is having grade 2 anterior vaginal wall prolapse and she is having a huge 10 by 9 centimeter cyst and adenomyosis. So, we are doing the abdominal procedure for her for the hysterectomy, and the cyst has to be removed. But now she's having grade 2 anterior vaginal wall prolapse also. So we need to do abdominal hysterectomy and open above 10 by 9 centimeter. It's huge. So we need to address this abdominally. But any case, just I'm taking a case scenario where we need to intervene from above. Okay. And there is a cystocele also, anterior vaginal wall prolapse. So how to address that cystocele? Okay,
there are two options. You can do abdominally also the cystocele repair, McCall's caldoplasty. So the cystocele repair abdominally, it can be done by plication of a pubocervical fascia,
inverted V.
Yes, and McCall's caldoplasty can be done abdominally also. And other option is after you complete the abdominal procedures, you again start doing the vaginal approach. The cystocele can be corrected.
Okay. So when we do it abdominally,
I prefer when I do abdominal procedures, I do abdominal McCall's caldoplasty and abdominal cystocele repair with paravaginal repair.
Paravaginally, how you do it
abdominally also, fixing the vaginal wall to the arcus tendinous, which is very easy in abdominal approach. Yes. And if there is a genital hiatus patulus, it has to be narrowed by doing the perineoplasty from below.
So when you do it abdominally cystocele, so which suture material?
Again 20 Vicryl.
And now suppose we are doing it, we prefer doing vaginal.
McCall's I do with the 20 PDS, abdominal McCall's caldoplasty.
And vaginal?
Vaginal 20 Vicryl.
Okay.
Internal McCall's caldoplasty I do with non-absorbable proline sutures. External McCall's caldoplasty I do with 20 Vicryl.
Okay. But why when we do McCall's abdominally, you prefer PDS and vaginally?
Because I'm not doing internal and external.
Okay,
so I do only one type of McCall's.
So
when I do internal McCall's vaginally, it should be non-absorbable sutures because it hold that portion of the vagina
above
to prevent the increased intra-abdominal pressure from straining. So that has to be done with non-absorbable sutures. Internal McCall's.
So, ma'am, suppose if you are doing vaginally the cystocele repair, abdominal procedure is done, uterus is out. So, it should be done before vault repair or after vault repair?
Which cystocele repair? Cystocele repair should be done in after hysterectomy.
But before suturing the vault or after suturing the vault? Because when we take the vault, because sometimes it goes up.
No,
so,
always cystocele repair has to be completed before closing the
vault.
Anterior vaginal wall and vault.
So we should. So basically, when you are doing abdominal hysterectomy and you have the cystocele, so you can do it both the ways. But if you are doing vaginally, remove the uterus and after, before suturing the vault, come up below, do the cystocele repair
and then close the
vault.
Vaginal wall and vault.
So laparoscopically also, I think same way. We do
same way, but the outcome compared to according to the evidence, because we are modifying so many techniques when we do laparoscopically and robotically compared to the open abdominal technique. So the evidence says the anatomical outcome and the functional outcome, there is a difference between the laparoscopic and the open abdominal technique.
So which is better, open or laparoscopically if you do?
They say, some studies say they are equally effective. Some studies say abdominal open route is more effective than the laparoscopic. Because the procedures are modified when it is done through the laparoscope compared to the open abdominal procedures.
Okay. So, ma'am, this was the anterior posterior compartment we have done. Now, coming to the apical. So, when there is wall prolapse or the prevention of surgery, future prolapse, what we do prophylactically, what are the procedures and which routes can be done to address the apical suspension?
Usually for stage 3 to 4 pelvic organ prolapse, after hysterectomy, if the vault descends below the introitus, we can go for vaginal sacrospinous fixation.
Okay.
If the vaginal length is longer, suppose if the vaginal length is shorter, you can go for bilateral iliococcygeus fixation, which has a good anatomical success rate, or we can go for high uterosacral ligament suspension. If the patient is sexually active with a very narrow vagina, and that patients can be with a huge stage 4 vault prolapse, that patients can be offered abdominal sacrocolpopexy or laparoscopic sacrocolpopexy.
And what's the rule about pectinopexy?
Pectinopexy, I have no experience in pectinopexy because I'm not doing that. I usually prefer sacrocolpopexy or vaginal sacrospinous, bilateral iliococcygeus, high uterosacral ligament, extraperitoneal high uterosacral I used to do a lot with a good follow-up. And for octogenarian patients, I go for colpoclysis, which is also a very good apical suspension procedures.
So, ma'am, as you said, high uterosacral used to do. How is the result? Which you prefer? What's your nowadays? What you do? What you prefer the most?
I prefer extraperitoneal high uterosacral ligament if the anterior vaginal wall is more longer than the posterior vaginal wall.
Okay.
If the posterior vaginal wall is longer, I prefer either sacrospinous or bilateral iliococcygeus.
Okay.
So the surgeon should go to the operation theatre with a spectrum of operations so that she or he can modify the procedure whatever suits the patient. So we cannot go to the theatre that I will do only this procedure.
Yes, you should know everything and you should customize, tailor what improv findings you see.
Yes.
Could you just please elaborate why is the reason, like when the anterior vaginal wall prolapse length is more, you prefer high utero ligament? What's the reason for that?
Because if we see by taking the anterior vaginal wall to the sacrospinous ligament, usually anterior wall recurrence is more common after the sacrospinous fixation.
That's
so
the
in
reason.
Such a scenario, already there is an anterior vaginal wall prolapse.
So do it the high
extraperitoneal high uterosacral bilaterally, that gives a good result. Even when the patient has increased intra-abdominal pressure, it will not be transmitted to the anterior compartment alone. So it is not prone to the recurrence. So I prefer bilateral extraperitoneal high uterosacral ligament suspension when the anterior vaginal wall is longer than the posterior vaginal wall. So if the posterior vaginal wall is longer than anterior, we can go for right sacrospinous fixation or bilateral iliococcygeus along with perineoplasty.
So sacrospinous fixation unilateral or bilateral?
Unilateral, right unilateral.
So why ileococcygis bilateral? It will not give unilateral ileococcygis suspension.
Because Schull, who was the inventor of the procedure, he says
That
the
it should be
evidence says it should be bilateral.
Bilateral only.
Bilateral.
Unilateral not.
Because it will not narrow the vagina and it
it's
is
the chances of
recurrence is less.
Less.
Especially
when
the
we do
anterior
bilateral.
compartment recurrence is less.
So any what's the experience of sacrocolpopexy? You do it with mesh?
Yes, it is always with the mesh. But I have done some research in abdominal randomized control trial.
Okay.
That is comparing the abdominal sacrocolpopexy with a synthetic mesh and autologous fascial atom.
Oh, yes, that's only
So my conclusion in my research was it was equally effective.
Okay, mesh exposure complication in long term.
In my study, there was no mesh exposure and mesh erosion, but usually mesh related complications can occur and it should be explained to the patient whenever we use mesh for colpopexy. Proper technique, proper selection of the mesh can reduce the mesh related complications.
Mesh polypropylene?
Polypropylene mesh, macroporous, monofilament, polysynthetic mesh is enough.
And I think we are done, ma'am. Best shoot we decided, but actually it's patient based. I think just for the conclusion, anterior vaginal wall prolapse can be addressed from both the routes.
Yes.
Okay.
But preferably vaginal route.
Prolapse, and as a urogynecology, always vaginal.
Yes. Less hospital
early
stay, early mobilization. So 90% of the surgeries we should aim for
vaginal is the best
route. And the FDA Food Drug Administration has in USA has prevented the use of mesh vaginally. So we are not using the mesh.
Mesh and then native tissue repair. And it gives a good result.
Native tissue repair along with the perioperative and long-term
I think that
pelvic floor muscle training with the usage of estrogen cream definitely aids the efficacy of our vaginal surgery. And lifestyle modification.
Post-op, when you tell the patient to start
after 6 weeks.
Estrogen cream.
Yes.
Okay, after 6
weeks.
And before operative, when to stop the estrogen cream?
It can be applied even before surgery. I don't stop it.
Okay, that is nothing.
Yes.
Twice weekly?
Twice weekly. Yes.
Okay, ma'am. I think
and we should also think of a colpoclysis for patients, fragile patients above 75.
You do it under local anesthesia?
No, under
general, but it's
regional or general, whichever is the patient, the anesthesia's choice.
But it's very good result for the recurrent and old fragileness. 75 years above, we usually prefer it.
It has a very good success rate if it is done properly. And we should see that there should not be a residual
vaginal length. That's why it should always be combined with high perineuraphy.
And levator myography is a must in these patients.
Yes.
So I always insist that the route of repair, the mode of approach should always depend upon the patient's goal and the patient's surgical risk factors, which starts from the inciting factors like decompensatory factors, aging, menopausal status, parity, all vaginal delivery. So we should account all when you plan a surgery for a patient. All should be included, starting from the patient's risk factor for not only for surgical risk, also for the post-operative recurrence. All should be considered.
Asthma, COPD.
All should be considered before we select the procedure and the route of approach. I think we can give the best to the patient. But always we should explain that the patients with the pelvic organ prolapse has the inherent capacity for rectal prolapse also. Those who do not have a rectal prolapse at your time of surgery for pelvic organ prolapse may come to you with a complete rectal prolapse 3 to 4 years later. So you should counsel the patients because the patients may tell you have corrected that because of correction of wall to prolapse. Now I have developed a complete rectal prolapse. So they should be counseled. There may be a need for management of complete rectal prolapse too. And stage 3 and 4 prolapse patients have a more chance for recurrence of POP later on because of the connective tissue lack in the uterosacral ligament. In spite, we attempt and give a good repair for such patients.
Are you offering any fellowship? Anybody want to learn?
We are planning to start.
Okay.
Yes, we will let you know shortly.
So anybody who is interested,
Yes,
can follow up.
definitely.
And I think 2025, by 2025, we'll come to know.
Yes, yes,
This
sir.
year, it will
Yes.
be a new hope, more urogynecologists
Yes,
and more
services.
training centers,
Yes.
we hope. So, thank you, ma'am, for
Thank you
this.
so much for interviewing me. Thank you so much.
Thank you, ma'am.
Thank you.
Thank you.